Hi, my name is Lori Bechard, and I'm an Associate Professor of Nutrition and Dietetics at Johnson & Wales University. Prior to my position in academia, I had a lengthy career in clinical pediatric nutrition and clinical research at Boston Children's Hospital, where I collaborated with many colleagues on some of the studies that I will discuss in this presentation. This course is just one in a series of subjects brought to you by Channel 1, On-Demand Nutrition Education. Today, we are looking at evidence in nutrition practice, specifically a look at global practices in PICUs around the world. Let's begin with this classic diagram of the sequelae of critical illness in a pediatric patient. The onset of trauma, major surgery, sepsis, or other critical illness triggers a shift in metabolism that promotes muscle breakdown to provide acute inflammatory proteins for tissue repair and wound healing. Thus, there's often a loss of lean body mass, and concurrently, poor utilization of glucose can lead to hyperglycemia and associated problems. As registered dietitian nutritionists, we aim to support patients during their critical illness and minimize their nutritional deterioration while hospitalized, knowing that growth and activity will be secondary to the demands of recovery from critical illness. There are many challenges in completing a nutrition assessment on a child with critical illness, including variability and heterogeneity in age, size, muscle mass, stage of growth and development, presenting diagnosis, medical and nutritional history, and severity of illness. Predictive energy equations developed for healthy children have been shown to be inaccurate, and use of these during critical illness may lead to over and underfeeding and associated morbidities. Enteral nutrition is the preferred feeding mode for most critically ill children and is associated with better outcomes. However, the care of a critically ill child involves multiple interventions, often competing with the delivery of enteral nutrition, including procedures, both elective and unplanned, and clinical sequelae related to their disease process and recovery. Planning and achieving targeted nutrient delivery may often be interrupted, poorly tolerated, or limited by fluid limitations or mechanical issues. Generally, there are three categorical areas that play a role in the provision of suboptimal nutrition: dynamic issues related to the patient status, individual, team, and institution-based provider expectations, and relevant professional practice guidelines and published research. Furthermore, global practice can be variable and may also impact outcomes. So several years ago, we started the Pediatric International Nutrition Study, or PINS, which were cohort studies of mechanically ventilated children in PICUs in several countries around the world to better define what comprised optimal nutrition support for critically ill children. We aim to determine the relationships between nutrient intake from enteral nutrition as well as parenteral nutrition and clinical outcomes in a large, diverse population of patients in PICUs, and to better understand practices associated with nutrient delivery and outcomes. The study design is illustrated here, with clinicians contributing to a centralized online data capture system. We completed this study during 3 time periods in 2008, 2010 to 11, and 2017 to 18, and we provided site-specific feedback, which some groups then went on to share and disseminate both locally and with colleagues around the world. We also published several analyses of these data, which have since been referenced in several guidelines documents for the nutrition care of critically ill children. In the main results from our first 2 PINS efforts, we found significant relationships between adequacy of energy and protein intake and mortality. Energy adequacy was defined by the clinician caring for the nutrition of the patient, and we captured the amount of energy and protein received daily for up to 10 days of PICU stay. We also captured 60-day mortality and measures of illness severity. Here you can see how in PINS 1, the proportion of energy and protein intake from both EN alone and EN plus PN increased daily, but never reached the prescribed goal, falling short at just over 50% for EN energy by day 10. In PINS 1, we also found a significant relationship between energy adequacy and mortality. Similarly, in PINS 2, we found that patients with low protein adequacy had significantly higher rates of mortality, especially, as shown in this graph on the right, among patients who had the highest levels of illness severity. In our third PINS, nearly a decade later, We examined not only the relationships between nutrient delivery and outcomes, but also the time to achieve 60% of the clinician-prescribed goal amount of energy and protein from both EN and EN plus PN. We chose 60% because analysis of the prior PINS studies data suggested that this was the level at which outcomes were improved. As shown in these bar graphs, we found a significantly higher risk of mortality among patients who did not achieve 60% energy or protein adequacy from enteral or combined enteral plus parenteral by day 7 of their PICU stay. When accounting for multiple covariates, we continued to find significant relationships among adequacy of nutrient delivery, the time to achieve the 60% adequacy threshold, and mortality. Importantly, there was a consistent association between nutrient delivery that was delayed more than 7 days and poor outcomes in this international cohort. In taking a step back at the time course of the PINS studies and other PICU nutrition-related research, we recognize the timing of some important contributions. The PAPANIC study, published in 2016, was a large randomized controlled trial of early versus late parenteral nutrition delivered in 3 ICUs in Canada, Belgium, and the Netherlands. The following year, in 2017, the revised version of the 2009 FASPEN guidelines were published as a joint effort between ASPEN and SCCM and reflected all the research to date, including the contributions of the PAPANIC study, as well as highlighting important gaps in the evidence. Since these seminal publications were disseminated after our first 2 PINS efforts, we considered how the changes in the nutrition research landscape may be reflected in practice. As a cohort study of nutrition practices, our third PINS cohort could reflect the influence of these publications, and with identical methodologies to PINS 1 and 2, comparisons could be made. So for this comprehensive look at the time course of nutrition practices in PICU settings from 2009 to 2018, we combined our first 2 PINS data sets to describe the nutrition practices recorded by bedside RDNs in this large multi-center international cohort of mechanically ventilated critically ill children admitted to PICUs over 2 time periods of data collection. We analyzed the differences in key areas of practice between the PINS 1 and 2, the pre-guideline cohort, and the PINS 3, the post-guideline cohort. This collaborative effort among many of the PINS investigators across the world was published in the December 2024 edition of the Journal of the Academy of Nutrition and Dietetics. For this secondary analysis, we examined many of the PINS data elements that were recorded in all 3 PINS efforts. We captured specific information about institutions and PICUs from each site and detailed data about individual patients who were admitted to the PICU and mechanically ventilated. Site investigators recorded daily clinical and nutritional data and a set of important clinical outcomes, including 60-day mortality, length of PICU and hospital stay, the incidence of hospital-acquired infections, and days requiring mechanical ventilation. Here you can see some of the characteristics of patients that were included in the 2 cohorts. We had 1,769 patients in the PINS 1 and 2 cohort, and 1,881 in the PINS 3 cohort, and a total of 235 patients died across the cohort, 6.4%. The median age was 1.75 years, and fairly similar in both cohorts. In the PINS 3 cohort, the proportion of patients who received PN was smaller, and the proportion of patients who received EN was larger than in the combined PINS 1 and 2 cohort. Most of the participating sites were in North America, but with an important contribution of patients from Europe and other countries as well. Here we show the relevant site information across the 2 cohorts, including a notable increase in the number of dietitian full-time equivalents per 10 PICU beds between the PINS 1 and 2 cohort and PINS 3. To be included in PINS, PICUs were required to have 8 or more beds, and you can see that the median size was more than twice that. As previously noted, most of the sites were in North America, and nearly half were in Europe and other regions worldwide, including Asia, Oceania, and South America. The primary outcome of this secondary analysis was the time and days from PICU admission to the initiation of parenteral nutrition and enteral nutrition delivery. To account for the clustered nature of the data at the site level, a frailty regression model was used to evaluate the association between the PIN's epoch and time to EN or PN initiation, censored to 10 days after PICU admission. To satisfy the proportional hazard assumption, the baseline hazard function was stratified by region. Confounding variables included sex, age, medical versus surgical admission type, body mass index Z-score, PICU size, and dietitian FTEs at the respective sites. These graphs show the probability of PN and EN initiation up to 10 days in the PICU for a medical patient when other variables are set to the mean value. A very similar figure for surgical patients shows nearly the same results in the manuscript. In graph A, you can see that PN initiation overall is highest in North America, shown by the black lines, but starts earlier in Europe, shown by the red lines. Note the differences by about PICU day 5 in the probability of starting PN in the PNs in pins 1 and 2 in the solid line versus pins 3 in the dotted line. There was also lower use of PN in regions outside of North America and Europe. In graph B, you can see the overall use of EN begins early and is highly prevalent. By day 5, the probability of starting EN is at least 75% in all cohorts and regions. EN initiation is lower, but not significantly, in North America compared to other regions, and not significantly different between pins 1 and 2 and pins 3 in any region. In the multivariable model of PN initiation, we found that surgical patients as a group were significantly more likely to start PN and significantly less likely to start EN than medical patients. And there was a 20% reduction in odds of initiating PN in the PINS 3 cohort, but no significant effect of cohort time on the odds of initiating EN. There was about 10% higher odds of initiating EN in PICUs with more dietitian FTEs. As secondary outcomes for this analysis, we also analyzed prescribed energy and protein goals with a multivariable mixed effects binomial regression model. The results here show that the energy goal in PINS 3 was 91.8% of the energy goal in PINS 1-2 for a patient with similar characteristics, but there was no significant difference in protein goal between PINS 1-2 and PINS 3. The results of our study suggest that patients in the PINS 3 cohort were less likely to receive PN than those in the PINS 1-2 cohort during the first 10 days of PICU admission, and that geographic region may influence the time to initiate PN or EN. Patients in participating North American PICUs were more likely to start EN later and more likely to begin PN sooner compared with patients in participating PICUs in Europe and other regions. Enteral nutrition is the route of choice, and it's generally started early during the PICU stay. In addition, we observed significantly lower energy goals in the later cohort, but no significant difference in protein goals. These findings are consistent with the major recommendations from current published guidelines, but further investigation of regional variations and the impact of site-specific nutrition algorithms and protocols should be explored. Thank you for your attention today. I would encourage you to watch for upcoming Channel 1 videos on nutrition and learn more on these topics from my esteemed colleagues. Have a great day.